Thank you very much. Good morning, everybody. First of all, introduce myself. I'm Dr. Mukherjee from Karlsruhe Heart Center in Germany. And like any other days in the operating room, I'm an anesthetist who is here before the surgeon. So in the surgical meet, to start as an anesthetist is really an honor. Can we have the slides, please? Oh, it's there. Okay, thank you very much. I'll be talking on a very burning topic, which is obviously in the Western world, which is being done on a regular basis. I believe there are some cases also done in India. So I'll be talking about the anesthetic care for transcatheter valves, which is obviously either replacement, and in Europe it is more known as as implantation. I have no conflict of interest, and typically all these patients are high-risk octogenarians. There are multiple comorbidities, so most of the patients are either having the following diseases like COPD or renal insufficiency, neurological disorders, and diabetes. This is a typical profile which you'll get in most of the patients in this or over 80 years of age. This all started with Dr. Crevier's implantation of prosthesis for calcified aortic stenosis. It was done at that time as a bailout procedure for a 57-year-old man. It was, and the patient actually made it 17 weeks after TAVI. And obviously it was declined for conservative surgery using sternotomy. So we have 14 years down the lane from that case, and it was that time the first case was obviously done in mild sedation and local anesthesia, because it was considered GA is actually general anesthesia is detrimental to the patient. But we have come a long way from that time, and I'll show you in the German registry, because I was previously 10 years in Leipzig Heart Center. And like I said, last year I moved to Karlsruhe as the chair, and this is from Mrs. Funkert. She is our statistician, and if you see there is a progressive rise from 2004 to 2014. About 42.3% of the patients who are more than 18 years old are done by the transcatheter method. So in Germany there is a huge rise in potential of transcatheter valve implantation. So naturally the anesthetists have to gear up to these comorbidities and high-risk octogenarians. So typically in a TAVI scenario, performed in a variety of anesthetic techniques, you have a lot of chances that you land up most of the cases. In 2012, when it started under the registry, it was all done on the GA, but then there's a trend also, which I'll show, and even in the US, they're shifting now to monitored anesthesia care. So TAVI, you have the transfemoral and transapical. Either you do it in conscious sedation or MAC, which is monitored anesthesia care, and then you have GA for both of the procedures in transfemoral and transapical. And specifically for really high-risk patients with lung morbidities, where the vital capacities are extremely reduced, you can have an option of thoracic epidural, which is specifically done by me and my colleagues in Leipzig in 2009, and we had published a case series in Annals of Thoracic Surgery in 2009. And like I said, several anesthesia regimens are possible and described both for general as well as for conscious sedation. GA, I am not going into the details of the medications. This is a typical profile where you do propofol and remifentanil, and anesthesia can be substituted, and when you need to convert, the anesthetist should be prepared to convert immediately to general anesthesia. So what are the main challenges for the anesthetists? They are all octogenarians, like I said. There is a lot of need for hemodynamic and volume management. What is very important, if you're going for a fast-track anesthesia, like we want to extubate either on the table or within 30 minutes of the surgery, you have to avoid hypothermia. And there are some scenarios where you have to be really prepared, like rapid ventricular pacing. For emergency bypass, TE monitoring is a must, and post-operative course and analgesia. These are the typical challenges for the anesthetist. What we do typically is the monitoring using ECG, CV catheters, introduce a sheath and outline. And what is important that you should have either a nasal or a temperature urinary central probe to measure the temperature, which is required for avoidance of hypothermia. And likewise, what we have in Germany, we use this monitor very often called narcotrend, where you do EEG monitoring, and it measures the depth of anesthesia as well as the sedation in case of monitored anesthesia care. And never ever forget this, because this is your lifesaver, because most of the times there is a high chance the patient with ejection fraction less than 30%, they're going to fibrillate after the rapid pacing, so you'll end up with external defibrillator patterns. That's the first thing I check into the operating room before I start the procedure. And like I said, in the balloon valvuloplasty and valve deployment, this is what you're going to see as a rapid reduction in the hemodynamics. So you have to make sure that the pacemakers are inserted either apex or through the groin, done by the cardiologist. What is important also the surgeon usually puts a surgical safety net where there is, in case you have to go into emergency landing into the bypass, you have this percutaneously inserted wires which enables you, so you have the other groin free for the procedure, and the surgical safety net is like a bailout procedure, and that saves time and helps you to go into emergency bypass if necessary. So this is, in my opinion, one of the major life-saving procedures from the surgical point of view. Looking quickly into what are the complications which are possible. Like you have the predictors outcome from a group of Faracos. He's a Fracaro. He said that typically if you're involving a core valve, which was that time one of the most highly deployed valves, and still I believe it's one of the most commonly used valves. And if you have a high implantation, that's obviously there's chances that you're going to land up in a rupture. But if you have a low implantation, there's a conduction disturbances. Initially, when we started with the procedures, Leipzig Heart Center had a statistics of 32%, which landed up with the AV block. But with our expertise and with the evolution with the new generation valves with Evolut R, it's around between 12 to 15% right now. And in our center, which we are doing about 700 to 800 TAVIs a year, our in Karlsruhe is about 14.8% of the statistics from last year. So regarding hypothermia, I would like to say some few words. What's first thing, if you have a patient which is shivering, naturally you land up with increased work of breathing, increased afterload, and decreased cerebral awareness. So this is something you have to keep in mind, because all this leads to delayed extubation. And if you have a delayed extubation, the length of stay is obviously prolonged, and the patient has to shift either to your intermediate care, because 90% of the patients usually don't go into the ICU because we use the fast track protocol, and then we go to the intermediate care, and where they're monitored on a telemetry bed on a normal station for the next 72 hours. So very important is hypothermia management from the anesthesia point of view. There are a lot of devices which is possible, and we have actually opted for this right from the induction room. We have pre-warmed cotton blankets before they are transferred to the operating room, and they have between 42 and 52 degrees Celsius. And obviously the forced warm or the bear hug or underbody for the complete induction of anesthesia. In the induction room, we have an induction room as well as an operating room with the operated. So in the induction room, the temperature management is used using the bear hugger. And what are the other measures which we use is obviously make the temperature in the operating room a bit higher, like 22 is the standard, we go a little higher. And we have the fluid warming, so all the patients receive through what is known as the hotline. We use whatever you are using, a Ranger or a hotline, really doesn't matter. Make sure they're getting pre-warmed fluids. And we have what is during the entire procedure, you should make sure that you're using the bear hugger. So quick look into what kind of anesthesia techniques would you like to prefer. When you are in your running phase, I obviously prefer to say the general anesthesia is better. It's got a wide variety of possible complications, and I have listed only a few of them here, and many of them can be immediately detected with a TE and with fluoroscopy. And operatively, the biggest advantage with GA is it offers the possibility of interprocedural guidance as well as monitoring with TE. So if you're using a new valve, for example, if you're using a Lotus or one of the newer valves, I would suggest that you start first with general anesthesia, because you have a better control of the imaging, because it depends on what kind of imaging you're doing. If you have something like as a fusion imaging, I would say that the fluoroscopy and TE is definitely complementary to each other. Disadvantages are also there. Not everything has got advantage. So there are sometimes, if you're inducing a patient with probably a little higher degree of propofol or something, they may land up in hypotension. You have to be very careful. Like if you have subendocardial ischemia, they already have compromised ejection fraction and output. So it may have an implication on your coronary perfusion, and the patient is likely to land up with a decreased blood pressure. So you have to avoid. There are some hemodynamic goals which you have to keep in mind. So you have to make sure that the patient is adequately hemoglobin and the hematocrit. If they're good, then go with a 500 to 1 liter of induction fluids. You have to avoid tachycardia. That is something which is very challenging, and you have to maintain the sequential AV rhythm, because there is chances that the patients come with conduction disturbance or what is known as atrial flutter or fibrillation. So that's something which you have to avoid. And obviously, like I said, to avoid the high degree of myocardial ischemia, make sure that we usually try to maintain a mean arterial pressure of 70 millimeters of mercury during the entire procedure. So I said, unfortunately, general anesthesia can impair the achievement of these goals. So let's see what's next. If you go into the temporal and the geographic trends, so European TAVI pilot registry, they actually show the local as well as general anesthesia, and there is a trend with the general anesthesia is decreasing and the local anesthesia increasing. Let's have a quick look into what's the type of anesthesia used in the participating countries. So if you really see, for example, Germany and Italy are mostly using monitored anesthesia care. And on the other hand, if you really see places like Denmark and United Kingdom, they're using general anesthesia for most of the cases. So there is a temporal and geographic trends according to your local expertise and the local trend in the hospital, which you have to keep in mind. Local conscious sedation, it can be done in many ways. Like I said, you have to have a plan in mind. Usually the protocol is using a low dose of remifentanil. I usually avoid propofol. With remifentanil and they are usually very, very calm. You can use Dex. Dex is a very good medication to be used intraoperatively, or catapresan. So that's something you have to make sure that the patient is absolutely free from pain, and whichever medications are used, there's a lot of way to go to Rome, so use the way which you feel the most comfortable. So intraprocedural imaging, like I said, if you are using general anesthesia with advantages of TEE, but that may be a constraint when you're using local anesthesia. But like I said, in case you have to crash down, you have to make sure that all your anesthetic gears are ready to convert into the general anesthesia. Thoracic epidural, that is also a procedure which we have done and published in Annals of Thoracic Surgery in 2009. We have used 16 patients. They were they were absolutely FEV1 by VC ratios were less than 40%. They were actually on oxygen therapy at home, and they were on they're very impaired regarding their daily way of life, so they couldn't even go to the washroom. So these are the patients where you typically benefit. There's advantages of thoracic epidural. The patient can communicate during the surgery, and when they open the chest, obviously you need some CPAP to prevent the negative intrapleural pressure. Intrathoracic pressure, and what is, in my opinion, the biggest advantage, they're completely pain-free post-procedure. So with this case series was actually done completely with one single surgeon, Professor Tommy Walter, and we had excellent results. So like I said, so which exactly is the best? I don't have an answer for that. There can be good, better, or the best. So whatever the theoretical considerations can affect the outcome of the patients. Like I said, if you use a fast-track protocol, using whatever, they don't see the ICU, they directly go to the PACU, intermediate care, and then the ward with telemetry beds. Intraprocedural imaging, obviously fluoroscopic has advantages. You have the better assessment of guide wires, catheters, valve stents. The disadvantages, obviously, if the patient, most of the patients come with an acute kidney injury, which may aggravate with this kind of exposure to radiation. So contrast dye, so these are renally compromised patients. That's something you have to keep in mind. So if you're using a Dynacity, that's the chances that you'll land up the whole procedure may be done with 25 to 50 milliliters. But if you're using any other mode, maybe you'll be exposing to between 100 to 125 milliliters of dye. So TE, sometimes you have some conflict with the anesthesia and the surgeons in between, where they tell you to go out or go in. So, but that's not an issue if you have a patient who is crashing. just go ahead and do the GE, and you can rule out pericardial and pleural effusion, which is very diagnostic and may be difficult to diagnose intraoperatively using the fluoroscopy. So what have we learned from the other interventions? So the Society of Neurosciences in Anesthesia and Critical Care that concluded, so they were like doing a lot of the endovascular treatment for acute ischemic stroke, and they said that LA is associated with lower mortality and better neurological outcome. But you have to have it, this is a limited by selection bias, so that's a complete quality of existing data is not sufficient to influence the clinical practice. That's the take-home message. And the same thing from the endovascular aneurysm repair, they have no influence on perioperative morbidity and mortality, irrespective of whatever kind of anesthesia you are using. So if you look into the data, in the electronic data, you go to the PubMed, Medline, MBIS, and Cochrane register, which I did in the month of February. I was going to present a talk in US and went through this. There was presently only one single meta-analysis, and they use this, what is known as the PICOS method. This is a group from Belgium. Dr. Rex and his colleague published that. They use what is known as the population intervention comparison outcome and study design. So these are all observational studies, cohort studies. They all took into account and made a kind of a meta-analysis, and they had actually, out of the 5,990 patients comprising of 10 studies out of the 512 studies which were cited in the electronic media. And they initially identified 563 records of which only 10 studies could be included in the systematic review and meta-analysis. So what do they say concerning the outcomes? Let us go quickly over the next, I have about 3 minutes, so I'll just quickly go into the outcomes in detail. The choice of a particular anesthetic did not affect all-cause mortality at the 30 days. Neither that 6.53% of the patients undergoing TAVI in LA died as opposed to a mortality rate of 5.53% in patients undergoing GA. So there is absolutely no difference in the all-cause mortality. So they landed up with either multi-organ failure or stroke, embolism, heart failure, perforation, or cardiogenic shock. So again, looking into their data, what about the incidence of major adverse cardiac and cerebrovascular incidents? So they also didn't differ statistically between LA and GA, the incidence of myocardial infarction and to the stroke rate. So there is absolutely, presently, there is no data to suggest LA or GA is better for these procedures. Acute kidney injury, the same story, there was no difference. And GA and LA did not differ concerning the incidence of vascular complications. Likewise, the rate of major bleeding was not also different from the two anesthesia techniques. So this is something we have to keep in mind. Till now, we are 1-to-1 ratio. And looking into post-operative scenario, the incidence of sepsis was also similar between both the groups. Both anesthesia techniques had the same procedural success rate. Well, 92 and 97 was similar, but a little bit difference, but I would say it is almost 90% plus. And they did not differ with respect to conversion to cardiac surgery. So intraoperative, whether you are using GA or LA, didn't have an influence whether you have to convert to bypass or not. Then, however, local anesthesia was associated with some remarkable benefits. So this has shortened the procedural times by nearly 35 minutes. This was probably mainly due to the shorter installation and emergency times, as the fluoroscopy time was not affected by the choice of a particular anesthesia technique. So the cardiologists actually, whether it was GA or LA, didn't affect their choice of anesthesia and the fluoroscopy time. What is very significant is the second advantage is the local anesthesia had a very significant shortening of hospital length of stay by nearly 2.5 days, which is something which your management would be happy to see about. Again, last but not the least, local anesthesia significantly reduced the necessity to administer adrenergic support. Again, like I said, paravalvular leakage and new pacemaker implantation at LA was incidence of was significantly higher in patients undergoing local anesthesia. But you may argue that, you know, the patient may be moving or things like that, but if you use a good monitored anesthesia care, this is unlikely the case. Like I said, you can do a meta-analysis, but they are like any other scientific study. These were the biases. There was no standardization of anesthesia techniques. So everybody used their own cocktail of every available anesthetics and analgetics. Before I conclude, I want to show you something what is known as a propensity score matching. And in this study, they had symptomatic severe anesthetics who had actually risk of morbidity and mortality. Even then, in the control and non-control group comprising of about 1,000 patients, and there were 45 match pairs, there was also no difference in the Kaplan-Meier curve. Some researchers have argued that the choice of anesthesia for TAVI might have an impact on the neurocognitive function, but these papers showed that this was probably, in my opinion, the very first randomized controlled trial on anesthesia in TAVI, and they could show that LA and GA didn't have any impact on the neurovascular outcome. That is something we have to keep in mind because this is something which is very detrimental. So if you're using an umbrella device like Claret, it also helps, but actually presently anesthesia does not influence your neurological outcome. Coming to one data which I wanted to show, more than the GA and the ALA, which rightly, like the anesthetist is of real concern, there are a lot of cardiologists who are doing it outside the operating room. So they did a study where there was one was done in a typical way. The question seems more important how and whom the TAVI should be performed. That cardiologists are pulling a lot of efforts in trying to get rid of the anesthesiologist. So as an example, I'd like to show you this study, and they compared, the approach was either in the standard way using the hybrid operating room and without anesthesiologist in the cath lab. And in this study, the cardiologists actually proudly concluded that the minimalist approach was much more efficient and no impact on the outcomes. So if you are a young anesthetist, it's no more in to date a surgeon, so it's better if you date a cardiologist because there's good chance that you have a better future. So conclusion, the choice of a particular anesthesia tag has actually no impact on the mortality or the incidence of major adverse cardiac cerebrovascular incidents. But this is something which you have to keep in mind, that the duration of the procedure, the length of stay, decreased antiarrhythmic supports, and pacemaker implantation increase. So that is something may have a slight balance on your GA and LA. So like I said, the length of stay and productivity LA, so you have to weigh, and the GA has operator-friendly, like TE intraoperative outcome. So you have to see what is, in my opinion, what is your institution is used to, how experienced are your surgeons, the cardiologists, what are they used to. If you're doing it routinely under GA, go ahead with doing a GA, but if you're LA, you have to have some amount of expertise. So it's patient cooperation and patient's choice is, my opinion, the first thing which you have to take into mind. And that's something for what is required right now is the need for prospective randomized control trial. Thank you very much for your attention.